Morning. Welcome. It's so nice to be here with you today. I'm just want to start by saying thank you to our Down Syndrome Clinic team who helped to contribute to this presentation about medical news of the past year. And I want to specifically thank my co-presenters, Kayla Kristensen and Kim Arndt. To start out, our team looked at articles related to Down syndrome that were published in the past year, specifically 2020, although we did also look a bit at 2021. And when we pulled up those articles, I got curious about how that number might have changed over time. There were 610 articles in 2020. And when I looked back, the number has really changed dramatically over the past 5 decades. And it was really exciting to see how research interest in Down syndrome has increased over this time. I'm going to start by sharing a couple of articles about obstructive sleep apnea and Down syndrome, and it's something that I think a lot about. This is a condition that affects as many as 80% of people with Down syndrome and can occur at any time during the lifespan. Untreated obstructive sleep apnea has been associated with a range of different medical and functional challenges. And obstructive sleep apnea and the associated cerebral hypoxia or low oxygen flow to the brain is identified as one factor that may contribute to risk for early dementia in people with Down syndrome. This first article comes from a group in Madrid, Spain. What they were looking at was they wanted to understand more about how common is obstructive sleep apnea in a large sample of adults and think about how that was related to body mass index or obesity, how severe the disease was, and how people responded to CPAP treatment. CPAP is continuous positive airway pressure, and it's one of the treatments that we use for people with Down syndrome. What they found was that about 73% of people had symptoms that were of concern for sleep apnea and were able to participate in a sleep study. And all of those people, 100%, that's such a dramatic number, had obstructive sleep apnea when they did the sleep study. And half of those people had severe obstructive sleep apnea. They did find that weight status correlated with both risk for having obstructive sleep apnea and also how severe it was. People who had the studies tolerated them well. The symptoms that they found were both daytime sleepiness, which wouldn't be surprising in a sleep-related disorder, but also alterations in behavior that were the presenting symptoms. And finally, they found that CPAP adherence, or being able to use CPAP, was actually really high. More than 79% were able to use the CPAP for more than 4 hours, and with an average of about 7 hours per night. And they also included some really nice supports to help people be successful with CPAP use. So the take-homes from this study are relatively straightforward, that people who have Down syndrome and clinical suspicion for obstructive sleep apnea had very high rates of obstructive sleep apnea in this study, that elevated BMI increased risk for obstructive sleep apnea and also for how severe it was, so weight status matters, and that it was possible to achieve high CPAP adherence with significant early supports. Moving on to another study about sleep apnea. This study was out of New Delhi, India, and was looking at how sleep apnea is related to behavioral and developmental differences in children with Down syndrome. And so they were looking at severity of sleep apnea and also development and behavioral challenges. And the behavioral challenges were actually identified by parent report, and they looked at developmental status based on a pretty straightforward developmental screener. Again, in this study, similar to the other study, they found a very high rate of people who had a sleep study had some degree of obstructive sleep apnea. In this study, not quite as many had severe obstructive sleep apnea, but still a very high number, almost 36%. And a higher AHI, which is a score that helps us understand how severe the obstructive sleep apnea is, was correlated with higher total scores on a behavioral measure. And what was interesting is that sometimes we think of behaviors as this cluster that we call externalizing behaviors. And so that's things like inattention, hyperactivity, being aggressive. But this study also found an association with what we call internalizing subscores, which were things like anxiety or being withdrawn or depressed. So a range of different ways that sleep apnea may be related to behavior, and also found elevated specific attention problem scores related to more severe obstructive sleep apnea. And finally, they found that more severe obstructive sleep apnea also correlated with lower cognitive functioning. So this is just another piece of information that helps support an association between increased obstructive sleep apnea and increased attention and behavior difficulties, and also increased obstructive sleep apnea and decreased cognitive functioning. Moving on, I'm going to share an article from the realm of physical therapy, and this study was titled Early Movement Matters. And what they were looking at was how early movement correlates with motor development. And it was a lovely study, and what they did was put a device called an accelerometer, a little tracking device, on the baby's ankles, and looked at how much they were moving based on that accelerometer, and correlated that with developmental scores, which were motor development scores, which were looked at over the first 18 months of life. At 2 to 3 months, they found that early physical activity was correlated with acquisition of tummy time and sitting skills. And by 5 to 6 months, greater changes in physical activity were associated with positive changes in gross motor skills. And this really is something to think about, because the streams of development, meaning motor development, language development, cognitive development, are interrelated. They're not separate lanes. And so seeing progress in motor development also contributes to progress in other areas of development. It impacts our ability to explore the world and experience new environments as we become more mobile. And the clinical takeaways from this study were really that we're right to consider early intervention as early as 2 to 3 months old, that motor skills do correlate with early physical activity. And to recap the title of the study, Early Movement Matters. Finally, moving on to the big medical topic of the year, and COVID-19 has really been the biggest news of the year, and its devastating impact has been felt widely in our community. It has impacted all of us with loss of lives, loss of employment, loss of vocational training, loss of school programming, loss of therapies, and loss of social opportunities in the community. I included this study, which wasn't specifically related to Down syndrome, but is hot off the presses because it's a very large study that illustrates how devastating the impact of COVID-19 has been on people with intellectual disabilities. This was a cross-sectional study of greater than 64 million patients across 547 US healthcare organizations. And what they found was that having an intellectual disability was the strongest independent risk factor for COVID-19, and was also the strongest independent risk factor other than age for COVID-19 mortality. The Trisomy 21 Research Society is a group of researchers that have been very interested from the start of the pandemic in understanding the impact specifically on people with Down syndrome. They've been putting out a series of reports sharing data from a survey that they've been collecting, as well as a survey from the UK, and they combine those data sources to help provide more information. What they've found so far is that people who are hospitalized with Down syndrome and COVID-19 have similar rates of fever, cough, and shortness of breath to people without Down syndrome, but have more frequent alteration of consciousness or confusion. They did find a few symptoms were occurring less, including joint pain and muscle aches and nausea and vomiting, but they also qualified this information by saying it's possible that people just weren't able to express all the symptoms that they were experiencing. People with Down syndrome experienced more frequent respiratory complications, so lung complications such as viral and bacterial pneumonias, and acute respiratory syndrome, which is a very severe respiratory illness, but experienced similar frequencies of heart complications, kidney problems, and anemia. This slide, I think, is very dramatically illustrates the impact of COVID-19 on people with Down syndrome. So this slide tells us about people who were hospitalized due to COVID-19 and their risk of death. And the blue lines represent people who don't have Down syndrome. And you can see that early in life, the rate of mortality is relatively low and that it increases significantly as people get into the older age groups. The red bars represent people with Down syndrome, and you can see that the rate rises much more quickly with age, and that by age 40, people with Down syndrome have an equivalent risk for death as people over age 80. Very significant. We have far less data about children, and children certainly are having overall less severe outcomes with COVID-19, but we know that some children are still at risk for severe outcomes, and we're trying to understand more about what the factors are that make some children more susceptible. The light at the end of this tunnel is that vaccination is here, and COVID-19 vaccination has been prioritized for people with disabilities with a range of disabilities in the state of Wisconsin, and the people over 16 and their direct care personnel, including paid and unpaid caregivers such as family caregivers, are included in the current priority groups in our state. For people who are joining us from other states today, the Global Down Syndrome Foundation does have a vaccine tracker on their website, and that is listed here. And there are lots of other good COVID-19 resources available. And if you're interested in more information, you can join one of these websites. And that ends my presentation for today, and we will transition to Dr. Arndt.
Hi, everyone. My name is Kimberly Arndt. I'm a rehabilitation medicine physician. I work for the Department of Health Services at Central Wisconsin Center, working with individuals with developmental and intellectual disabilities. I'm also affiliated with the UW Department of Orthopedics and Rehabilitation. I'm going to be talking to you today about Down syndrome adult medical guidelines. This is a brand new set of guidelines that came out in the fall. I have to tell you that I have a personal and professional interest in Down syndrome. I have a 6-year-old daughter with Down syndrome who is amazing. And so because I've been inspired to be involved with this population, I am now part of the Down syndrome medical interest group for the United States. And I'm also vice president of Gigi's Playhouse Madison Board of Directors. All right, so we are going to talk today about an article called The Medical Care of Adults with Down Syndrome, a clinical guideline. This came out in the Journal of the American Medical Association in October of 2020. This was really the first study to create medical guidelines for adults with Down syndrome. The research was performed by Global Down Syndrome Foundation through a work group with the goal of creating a clinical practice guideline that could be then shared with other healthcare providers. So why is this important? Pediatric Down syndrome guidelines were published in December of 2011, so almost 10 years ago. And adult guidelines are important because life expectancy has increased for adults with Down syndrome. So in 1983, about 40 years ago, life expectancy was 25 years. And now life expectancy is 60. So people are living longer and chronic medical conditions need to be evaluated and managed. Despite Down syndrome being one of the most common genetic chromosomal abnormalities, there's very little research to base recommendations on. So this study looked at research surrounding a few different topics. So there's 9 topics we're going to cover, including behavior, dementia, diabetes, cardiac disease, obesity, atlantoaxial instability, osteoporosis, thyroid disease, and celiac disease. The thing to note is that most of these recommendations are considered weak just because there is very limited research on individuals with Down syndrome. So there's not a lot of research to back up these recommendations, but they are still clinical practice guidelines that should be followed. And it's really using the best research that we have available at this time. So first, we're going to talk about behavioral health. So behavioral and mental health conditions are common in the general population and in individuals with Down syndrome. But many clinicians are not familiar with the types of behaviors you might see in Down syndrome. So, and the thing is people with Down syndrome could have typical symptoms of mental health disease, or they may have atypical symptoms. So the recommendations in the practice guideline is that if mental health concerns exist, the patient should be referred to a clinician familiar with Down syndrome. That's the ideal. However, it is difficult to find a provider that's familiar with developmental disabilities, and it's sometimes difficult to find a psychiatrist or psychologist that's comfortable treating individuals with Down syndrome. This obviously varies based on your location and types of healthcare resources that are available where you live. Medical professionals should follow typical diagnostic guidelines for mental health disorders, but there are ways to adapt the criteria to people with developmental and intellectual disabilities. Providers should review behavioral, functional, adaptive, and psychosocial factors or changes for individuals, and they should evaluate for medical conditions that can present with psychiatric and behavioral symptoms. This is a brand new recommendation for people with Down syndrome regarding behavioral health. Next, we'll talk about dementia. There's obviously an increased risk of dementia in adults with Down syndrome. Most of us are probably aware of that. But the thing is that there's a very low prevalence of dementia for individuals under age 40. So dementia-like symptoms can be due to medical conditions, and that needs to be considered. So the recommendation is that we need to be cautious about diagnosing age-related Alzheimer type dementia in adults younger than 40 years of age. We should be ruling out medical causes, especially treatable conditions. Studies really show that there's a less than 1% chance of having dementia if you're under the age of 40 with individuals with Down syndrome. So there's about a 10 to 20% prevalence of dementia once you're in that 45 to 49 age range. It increases to 30 to 50% for ages 55 to 59. And then it's almost universal, 90 to 100% if you're over age 65. The other recommendation is that we should be interviewing caregivers and families about changes from an individual's baseline. And that should be occurring annually starting at age 40. So this is the strong recommendation that that really came out of this paper, is that there is good evidence to show that we should be starting these conversations at age 40 to establish a baseline, because then we can be more accurate about diagnosis and planning. So these conversations should include cognition, memory, executive function, behavior and personality, and whether these are changing, communication skills, adaptive functioning, ambulation and motor skills, and also just talking about whether any skills are declining. And this is a brand new recommendation for individuals with Down syndrome as well. So for diabetes, diabetes is more common in people with Down syndrome compared to the general population, but it's only about a 3% higher prevalence. So we want to screen individuals for type 2 diabetes every 3 years, starting at age 30. So this can be done with a fasting glucose level or a hemoglobin A1C level. And if an individual is obese, we should be screening every 2 to 3 years, starting at age 21. So this recommendation differs a little bit from the general population. They recommend starting screening at age 30 rather than age 45, pretty much because individuals with Down syndrome seem to have more advanced aging. So the earlier screening is recommended. And then the other change is that screening for obese individuals is every 2 to 3 years rather than every 3 years for the general population. For cardiovascular disease, there's limited evidence that individuals with Down syndrome may have a decreased risk of heart attack, but that there's also limited evidence that they may have an increased risk of stroke at a younger age. This is really only based on one study, however. And this is probably due to the history of congenital heart disease that's associated with Down syndrome. So the recommendations are that we should be assessing whether cholesterol medications are needed every 5 years, starting at age 40. And this can be done using a just general 10-year risk calculator that primary care physicians use. Risk factors for stroke should be managed per regular guidelines. But the difference is that individuals with a history of congenital heart disease should have a periodic cardiac evaluation, and they should have a monitoring plan that's reviewed by a cardiologist. So as you can see, there's a couple general recommendations that are pretty much the same as the regular population, but that if you do have that history of cardiac disease or congenital heart disease, that you should be evaluated by a cardiologist, and that part is a new recommendation. Obesity is a common concern for adults with Down syndrome. There's a lot of factors that can contribute to this, but weight loss or weight stabilization is possible through activity interventions and diet. So the recommendations are to calculate BMI annually and monitor for weight changes, follow general recommendations for weight loss interventions, and really all adults with Down syndrome should follow a healthy diet, get regular exercise, and monitor caloric intake, and focus on overall wellness, which is the same type of recommendation that we have for the general population. Atlantoaxial instability is extra movement between the top 2 bones of the neck. It's a known risk in Down syndrome because of the lax joints and ligaments that are present. So there's really about an 8 to 10% prevalence of atlantoaxial instability in adults less than 30 years of age. So the recommendation is that neck x-rays should not be used to just screen people for risk of spinal cord injury and screen for atlantoaxial instability. There are no studies that have looked at whether x-rays can identify individuals that are at risk for spinal cord injury. And spinal cord injury from this condition is really uncommon. There's only 40 documented cases. And when you think about the huge population of people with Down syndrome, that's a very small number. There's actually no reports of spinal cord injury from Special Olympics over 20 years of participation. And we have to consider that there are risks of participation, but there's also risks of not participating in athletic activities for physical and psychological reasons. So providers should be reviewing signs and symptoms of spinal cord injury at every year, and they should be using a shared decision-making approach with families and caregivers and those individuals and consider benefits and risks. So for osteoporosis, we really don't know how frequently this occurs in individuals with Down syndrome. Studies really show kind of a wide range of prevalence estimates. There are no studies that have actually looked at how well bone mineral density testing works for people with Down syndrome, whether it's accurate, and there are no studies that look at the treatment for osteoporosis in individuals with Down syndrome. So the other interesting thing is that some individuals with Down syndrome may have decreased bone formation, which is different compared to increased bone resorption, which is the typical cause of osteoporosis. So medications may work differently or may not be effective for people with Down syndrome. So the recommendation is that really, because it's so varied and there's no research, they can't recommend for or against using established osteoporosis screening guidelines. So again, providers need to take into account that individual and their risks and benefits to doing this type of study. All adults that do sustain a fragility fracture, osteoporotic fracture, should be evaluated for secondary causes of osteoporosis. So that screening for secondary causes is consistent with the general population, but obviously kind of that can't recommend for or against is different than what we would do with the general population. Thyroid disease is common in Down syndrome, so 40 to 60% of people have this condition. The hard thing is that symptoms of hypothyroidism are also things we see in Down syndrome, constipation, weight gain. So because it's hard to separate out those symptoms, the recommendation is to screen for hypothyroidism every 1 to 2 years, starting at age 21. And this can be done by getting a TSH level. And so this is a new recommendation. Celiac disease is more common in Down syndrome, so 11% prevalence. But the symptoms can be difficult to recognize, again, because constipation, diarrhea, those types of things can be seen in people with Down syndrome, even without celiac disease. So the recommendation is that there should be an annual assessment for symptoms of celiac disease using kind of history and physical exam. So that is all the information from the article. I did include links to the pediatric healthcare guidelines for those of you with younger kids and the adult healthcare guidelines that we just talked about. Thank you so much for listening.
Hey, my name is Kayla Kristensen, and I'm the speech language pathologist in the Down syndrome clinic. I'll be highlighting some recent studies related to word combinations. One question often asked by families is, when will my child start putting words together? Romano and colleagues highlighted some interesting findings after studying 19 children with Down syndrome and modeling their communication development over time. They identified a relative strength in use of gestures, with more gradual addition of single words and word combinations. For example, use of word combinations around 26 months, and by 3 years of age, use of about 1 word combination in every 10 minutes of play. The researchers highlighted the need for further research with larger groups of children with Down syndrome, as well as the importance of pairing that information with individualized assessment, and the exciting opportunity to leverage this strength and use of gestures. This brings us to our second question of, how can I help my child learn to put words together? Foster Cohen, Bijsterveld, and Papp highlighted the importance of pragmatic language skills, or how language is used as an important predictor of early word combinations. A significantly larger vocabulary size, about 300 words, was also associated with later word combinations compared to the general population's finding of about 50 to 100 words. The researchers highlighted the importance of expanding functions of communication, from sharing personal information to expressing emotions, as well as the importance of focusing on building the number of words that we're understanding and using. So how can we build from this relative strength and use of gestures? We have some ideas here for your later reference, everything from encouraging use of a variety of gestures to responding with meaning to a child's use of gestures to help with that language understanding and later use. And how can we extend further from a relative strength in gestures? Quinn, Kaiser, Ledford, and Babb and colleagues highlight the importance of use of augmentative and alternative communication strategies, or AAC strategies. And before we jump into the specific studies, always important to highlight that use of these strategies with spoken words, tools like sign language, gestures, pictures, symbols, and speech generating devices, they should always be identified after specialized and individualized assessment to make sure that the strategies are really tailored to the individual. Also important to note that use of AAC strategies with spoken language has not been shown to interfere with speech or spoken language development. And instead, for children with Down syndrome, we're seeing some exciting gains in areas important for word combinations, like vocabulary and expansion of communication functions. So how does this look in day-to-day activities? Quinn, Kaiser, Ledford identified for preschoolers with Down syndrome use of speech-generating devices during shared reading activities and its association with gains in vocabulary and word combinations. Babb and colleagues highlighted for adolescents with Down syndrome, use of an AAC video visual scene display was associated with increases in independence of completing volunteer activities, as well as increased interactions with co-volunteers. Our next studies were prepared by our amazing occupational therapist, Jacqueline Bender, and focus on leisure and participation. So how can we increase participation in leisure activities for adults with Down syndrome? Mihaela and colleagues identified some important facilitators and barriers to participation in leisure activities. We wanted to highlight that when leisure was implemented in established routines, adults self-initiated leisure activities, and connections with the community and community programs were identified as important facilitators, while barriers included lack of nearby places, friends to engage with, and transportation. We wanted to recognize that we're all currently experiencing new barriers to our participation within the context of this pandemic. So we've included some ways that we can be a facilitator both now in our current context and look into the future. And that could be things like providing visual choices for virtual options. In the context of hot off the press research, we also wanted to highlight hippotherapy as a potential physical leisure option. There hasn't been a ton of long-term research and use of hippotherapy for individuals with Down syndrome, but recently Portaro and colleagues highlighted for 15 individuals with Down syndrome who were using hippotherapy associated gains in gait, balance, and stability, as well as hippotherapy being a great source of proprioceptive input. So we hope that these virtual options and socially distanced options will spark some conversation about leisure activities both now and as we look to the future. Thank you so much for your time, and thank you to our team. We have some references here, and we look forward to your questions.